Hi, I'm Jennifer Clark. I'm the news director at WJER Radio in Dover. Today you are tuned into DMG TV2 Medical Minutes. In the first show here today, we'll have three guests. The first one is Dr. Andy Worley from Dover. He's going to tell us about glaucoma. And then Dr. Walter Randolph will explain cervical cancer and what we need to know. Then Jacob Glick, a nurse anesthetist, will visit us here from Altman Hospital. It's Nurse Anesthetist Week. So stay tuned. You'll want to know all this information about your health here on DMG TV2's Medical Minutes. Hello, welcome to DMG TV2's Medical Minutes. I'm Jennifer Clark from WJER Radio, filling in on TV2 today. Our first guest on our first show is Dr. Andy Worley. He is with Vision Care Associates in Dover. And January is National Glaucoma Awareness Month. So we had Dr. Andy come on over and he's going to explain to us about what glaucoma is and how it will affect you. But first of all, tell us a little bit about Vision Care Associates. How many different doctors are in your office there on the Boulevard in Dover?
We have two ophthalmologists, myself and Dr. Tom Perkowski, and we have an optometrist, Dr. Aaron Lehman, with us. And then my cousin Tim Worley runs our optical there, the optical shop. So
it's a family business.
It is. We've been there since 1952. My grandfather started the business, and then my father, and now I'm there, and Tom and Aaron joined us.
All on the same location in Dover?
Yes, a new building now, but the same location, right.
And it's a much bigger building. How do you like it?
We like it a lot. It's fitting our needs very nicely now. So.
And how many patients generally come into Vision Care Associates?
We might see 30 to 40 patients a day on a busy day. So.
Wow, you need that big parking lot.
Yeah,
they can
yes,
spill over into the WJER parking lot right next door.
They might.
Well, we did bring you in today to talk about National Glaucoma Awareness Month. What's glaucoma? Obviously an eye disease.
It is. It's an eye disease that can affect one or both eyes. And the hallmark of glaucoma is progressive damage to the optic nerve in the back of the eye.
And that optic nerve, that takes those visual messages to your brain, right?
Right. They go from the eye to the brain. And glaucoma, the pressure or the susceptibility of the optic nerve to normal pressure causes progressive damage, and it takes the vision from the outside in, so it can be very hard for the patient to detect until it's very far advanced.
Can you get little blind spots, or does it all just come to a close?
Yeah, it generally starts as little blind spots out in the periphery, and then they work their way towards the center generally.
Is it too late then to get any treatment?
It's never too late to get treatment. But we like to pick it up at an early stage and start the treatment early so that we can prevent it from getting worse over time.
All right, and then tell us a little bit about this pressure, because when you're talking about glaucoma, the drainage for the internal fluids are blocked. And so it's not that you're crying, it's that your eye has to drain inside, right?
Right, the eye is circular like a balloon, and it has fluid in it, and that fluid is produced inside the eye and it's drained from inside the eye, and it never comes to the surface like tears do. And this fluid, if too much is produced, the pressure can build up, or if it's not drained quickly enough, the pressure can build up and cause a higher pressure than average. Normal pressure is from 10 to 21 when we measure it. Most people will fall within that range. Glaucoma can occur with a high pressure or with a normal pressure as well, so it can be tricky to pick up sometimes.
And when you say pressure, it sounds painful. What are some of the symptoms?
Yeah, generally there's no pain or symptoms with the most common type of glaucoma, and so a patient may not even know they have it until it's very far advanced, right?
So on an eye exam, they would test for glaucoma?
Yes, we do. We check for that routinely. And we check the pressure. We also look at the optic nerve to see if it looks like there's damage on the optic nerve.
And do a lot of people have glaucoma?
Well, in our practice, a lot do, but you know, it's about a 1% to 2% incidence or prevalence in the country, which means about 2.5 million people have glaucoma in the United States.
And when you say 1 or 2%, it doesn't sound like a lot, but a couple million people,
Yeah.
that's a lot of people.
Right.
So who's at risk for it? Do you have to be a certain age? Is it something some damage maybe you occurred during your lifetime? How do you get glaucoma?
Well, the most common type of glaucoma we're going to see mostly in older folks. So, mostly we're going to see it in people 50, 60, 70, 80, 90. The longer you live, the more likely you are to have glaucoma. So,
kind of like the older you get, you have more tendency to need glasses.
Sure. It's a blessing to be older, but there are some things that come along with that.
Anything that you can do to prevent it? Diet, exercise? How can you stop it?
No, there's really nothing you can do to prevent it. The best thing to do is have an eye exam at some point, especially if you're in your 50s, 60s, and if you've never had eye exams before, you ought to have an eye exam to have a baseline screening for glaucoma. And usually we can kind of see if there's any risk factors there and give you an idea of how often you should have your eyes checked after that.
Is it hereditary?
It can be hereditary. About 10 to 15% of first-degree relatives of someone with glaucoma will end up having glaucoma. So it's not absolute. It doesn't march right through families, but you are more at risk if you have someone in your family, in your immediate family, that has glaucoma.
If you're just joining us, we are talking about National Glaucoma Awareness Month, and with us is Dr. Andy Worley from Dover, from Vision Care Associates, and we've been talking about the different types of glaucoma. Well, if you do get it, what can you do? Do you just go blind?
No, our goal with treatment is to preserve your vision for the rest of your life, and there's two main types of glaucoma. There's sudden or acute glaucoma. That's where the pressure builds up very quickly in the eye, and there's pain and nausea. And
so that one is painful.
That one is painful, and you know it when you get that one. People with thick glasses who are farsighted are at risk for this type of glaucoma. And it can also be prevented, and it can also be treated with a laser treatment to open up the iris and let the fluid get into the drainage canal.
And when I think of laser surgery with eyes, I think of LASIK surgery so that I don't have to wear glasses. But it's probably something different for glaucoma.
Different. It is different. It's a different laser and a different use of the laser. The most common type of glaucoma, the open-angle glaucoma, the pressure just builds up because the drainage doesn't happen quickly enough, or the fluid's just produced too quickly, and there's no symptoms with that type of glaucoma generally. The laser that we can use for that type of glaucoma is different. We use it to treat the drainage canal in the eye to try to speed up the fluid draining from the eye to lower the pressure. But the vast majority of people are treated with glaucoma with eye drops, medicated eye drops.
That you have to take every day?
Yes. Some once a day, some twice, some 3 times a day, depending on the type of drop that we use.
That sounds a whole lot easier than laser surgery.
It's actually harder than laser surgery because it's something you have to do every day. The laser surgery is something you can have done once, and if it works well, you might put off drops, or a lot of times we use the laser for someone who is on drops and just not responded as much as we want, so then we'll do the laser, and that helps as well.
And one quick question about treatment. You'll often hear that medical marijuana will be able to treat your glaucoma. Is that true?
It's true. Marijuana does lower the eye pressure. It's not practical for most people to use marijuana as far as smoking marijuana. And it would have to be done several times during the day, which if you were trying to have a job and hold down your life, that wouldn't be a good thing.
No.
They've tried to make eye drops out of marijuana, products, and they just haven't worked out very well. So it doesn't seem to be a great treatment for marijuana, as much as some people might like that.
Well, as far as the seriousness of glaucoma, though, you should be screened and you should go see your eye professional, right?
Yes, that's right. Yeah. Many people are seeing their eye doctors on a yearly or every yearly basis for glasses or contacts, and they're going to be screened for that. But if someone doesn't wear glasses and they just don't ever see an eye doctor, it's a good idea to have a screening exam for glaucoma. In your 50s or early 60s would be a good time to do that.
All right, very good. National Glaucoma Awareness Month is this month, January, and all this great advice coming from Dr. Andy Worley from Vision Care Associates in Dover. And for DMG TV2's Medical Minutes, I'm Jennifer Clark. Hi, welcome back to the DMG TV2 Medical Minutes. I'm Jennifer Clark. You may know me from WJER Radio in Dover, but today we are talking with a New Philadelphia gynecologist, Dr. Walter Randolph. Welcome to TV2's Medical Minutes.
Thank you for having me.
And we have Dr. Randolph on today because we want to talk about cervical cancer. There is a lot of publicity about all kinds of different cancers, lung cancer, breast cancer. However, among women, cervical cancer is actually, the prevalence is decreasing because of all the screening.
Correct.
And so I want you to explain, let's start out, what is cervical cancer?
Well, on the cervix, there are several different cell types, and things can alter how those cells grow, which cause them to become abnormal and then eventually can cause them to become cancer. So what we're trying to do is trying to find things as they're changing before they turn into cancers. Most women don't feel their cervix, they don't know it's there, they don't have a lot of symptoms. So trying to explain where the cancer is or if you can feel it, they don't notice a lot there.
It's still very scary every time you say the word cancer.
Correct.
So you want to find ways to prevent that, and of course you said screening, and screening has become the most successful at preventing disease as far as cancer screening for women.
When the Pap smears were first developed, the cervical cancer was very common, and with general screening of the entire female population, we've seen its number of cases reduce significantly to where we, even as a specialist, if I see one case every other year, that's about it. And so we're catching most disease before it becomes cancer, which allows us to treat it without having to be as invasive and without having to disrupt a woman's life as much because we're picking up early.
And other things that you're picking up early are human papillomavirus, or HPV.
Correct.
And that sort of signals that cervical cancer could be developing.
Right. What we found through studies was that there was something that was causing the cells on the cervix to change and then develop into cancer. And through research over the years, what they determined it was HPV. Now there's multiple types of HPV. Some of it is more cancer producing than others, but we know that almost all cervical cancer is due to HPV. So now we even know that even by doing the Pap, we can pick things up, but even by testing for HPV, we can see if someone's risk is high or low, to the point that we can find how to screen them even before there's any change. So,
well, I don't know any women that like to go in every year for their Pap smear, but there's so much information to get just from a single Pap, right?
Correct. And obviously, no one ever likes coming to see the gynecologist. I mean, us and the dentist are down here way low on the priority list. But there is so much that we can find out from the Pap, and not just from the cervix, but that's our biggest screening event, and as well as the breast and the uterus and the ovaries. But the material that we gain from the Pap, like I said before, has changed the risk factors for women so much. We don't see as much cancer. So it's important. They may hate it, but it's important.
And the new HPV vaccine, is that important to get as well? It's a series of shots, right?
It is. It is. It's a series of 3 shots. Recommended for women or girls between the ages of 9 and 26. And the reasons for the ages has to do with risk factors. But by giving that, you can prevent 80 to 90% of cervical cancers and
80 to 90%, that's a lot.
That is quite a bit. That is quite a bit. And that's made a significant change in where the screening will go in the future. Young women have less of a risk, so how will they be screened in the future? Since they've had the vaccines, we'll have to see. But we know that it's preventing even more cancer.
And other ways to prevent the virus is to avoid risky behavior as well.
Correct, correct. I mean, if you don't come in contact with the virus, your risk for developing any disease is much less. So protection with sexual intercourse and avoidance of contact with HPV is your best bet.
Now, are there any symptoms?
Usually not. Usually not. Some women may have spotting, bleeding, bleeding with activity.
Which could happen for any reason.
Correct, correct. So that's why you don't just wait to see if you have symptoms. You come in and be screened, because by the time you have symptoms, you usually have significant disease. So you could look at it by saying, well, I'm not going to do my mammogram until I see a big lump. Well, by then it's too late. So why wait till you have bleeding to do your Pap? Do it beforehand. If there is something to be found, we can take care of it before it ever turns into cancer.
Now, we're very clinical about this, but you think just, the average woman on the street is thinking, great, one more test I have to take, and, your dignity's out the window. How do you handle your patients? How do you make sure that they're at ease and that this is really important to screen for?
Well, we try and stress just that it's so important. We know that it's a very personal exam, and we try and foster that I guess relationship with our patients to where they're comfortable seeing us and they know that what we're doing can make such a big difference. We know nobody wants to be there. We know it can be uncomfortable, but we try and make it better by taking our time. And I think patients are really realizing that it makes a difference and that it's worthwhile to do.
We normally get a Pap smear every year. But if you are HPV free, maybe you don't need a Pap every year.
And the latest recommendations that came out from from several groups, including the American College of Obstetrics and Gynecology and several others, have looked at that and said, if you have a woman who has been normal with her Pap smears and over the age of 30 and is HPV negative, she can space her Paps out. And some women are coming every 3 years, some are coming every 5 years. And that's throwing some women off because for years we've told them, come every year, come every year, come every year. So we're still telling them to come in.
Yeah, the annual exam is needed. You may not need the Pap, though.
No, but you may not need the Pap. And that is based on science. Everybody worries about, is it healthcare policy or is it insurance companies? No, this is based on science. And that is the biggest change that's happened just in the last year.
All right, so if you have any questions about cervical cancer or human papillomavirus, always call your doctor, right?
Absolutely, absolutely. And that's a big part of our job, is educating our patients so that they know more about the disease. So if you know who the enemy is, you can help fight them.
Very good. Our guest today on DMG TV2's Medical Minutes has been Dr. Walter Randolph. He's a gynecologist here in New Philadelphia. And for Medical Minutes, I'm Jennifer Clark. Welcome back to DMG TV2's Medical Minutes. I'm Jennifer Clark from WJER Radio in Dover. And on this segment with us today is Jacob Click. He is a nurse anesthetist. Did I say that right?
Yes.
And what do you do?
Well, I provide anesthesia care at Altman Hospital.
And when you say anesthesia, you put people to sleep before their surgeries?
Yes.
And there's got to be a variety of anesthesias out there.
Yeah, there's 4 common types of anesthesia. There's general anesthesia, which is the one most people think of when they think of anesthesia.
When your whole body's
you're
asleep.
Completely asleep. And then there's something known as regional anesthesia, where we utilize local anesthetics along with some narcotic to basically block a certain segment of your body so that you don't sense any pain.
Like an epidural
That would be
during
an epidural
childbirth.
During childbirth, or an interscalene block for a shoulder surgery or any type of upper or lower extremity surgery. And then there's something known as monitored anesthesia care that's referred to as MAC. And what that is we give you a deep level of sedation that we have to maintain, maybe help you support your airway to some extent, but you still breathe on your own and you don't require the depth of anesthesia that's associated with a general anesthetic. And lastly, we can and do conscious sedation as well.
That sounds like two different things, conscious and sedated.
Yeah, it's basically how sedated you are.
So you're kind of awake.
Yeah, exactly. So for a colonoscopy, an EGD, that would be a good example of conscious sedation, or even a MAC, depending on how relaxed you need to be to allow the surgeon to do his procedure. Then a MAC would be something you would have for, let's say, an inguinal hernia or a breast biopsy.
And who determines what kind of anesthesia you need? Is that the
Well,
surgeon? Is that you?
It's actually it's both the surgeon and the nurse anesthetist or anesthesiologist, and also the patient. If the patient's not going to be cooperative and isn't willing to, you know, have the chance of having some recall intraoperatively, then obviously we just do a general anesthetic.
So you don't want to remember the surgery.
Right. But if a patient understands that they will not feel anything and they're okay with a certain degree of sedation, then, you know, we can do a MAC or a conscious sedation for the procedure.
Now you mentioned an anesthesiologist and you're a nurse anesthetist.
Yes.
What's the difference between the two?
Well, primarily it's the education leading up to your anesthesia residency. And a nurse anesthetist background is in nursing, and an anesthesiologist background is in medicine.
When you think of anesthesia, I always think of, you know, the adverse effects. Does everyone get sick when they wake up?
Not everyone, believe it or not. That is the most common and the most feared complication post-operatively.
Yeah, nobody wants to feel like they have the flu.
Correct, yes, no one wants to vomit. But the incidence is actually not that high. It depends on some certain risk factors. Women who smoke are less likely to become nauseated post-operatively. Women who don't smoke have a higher incidence. You know, if you have a predisposition to motion sickness, you can have a higher incidence of nausea, vomiting after a general anesthetic. So there's some risk factors associated with it. And obviously, if you've had nausea with surgery in the past, then you're at a higher risk of having it again.
So have any of your patients, do they wake up and just throw up right on you?
It can happen, and it has, but it's not as frequent as people fear. Yes, the antiemetics we utilize and the medications we use, they do very well in helping to alleviate that symptom.
And when people wake up, are they crying? Are they laughing? And is that an effect of the anesthesia?
They can. Usually they're very sedate and slow to wake up, depending again what type of anesthetic you've provided. You know, usually how they go to sleep will be a good indicator of how they're going to be when they wake up.
So they have to count from 100 backwards?
We don't do that too often. You know, if they ask to count, we allow them to, but typically we ask you to take 4 deep breaths, and by the time you're on your 4th breath, you're unconscious. So it doesn't take long with the induction drugs we utilize today.
Wow, and how has that changed?
Well, in the last 12 years that since I've started, it's changed significantly from the decade prior to that. We utilize some very short-acting, very safe and IV induction drugs now that don't have the side effects that the drugs that were utilized the decade prior, you know, they had then. So.
Yeah,
It's
how
gotten a lot safer.
do you calm fears like that? Okay, I don't want to get sick, or I don't want to wake up during the surgery, or I want to make sure I do wake up.
Sure. Well, communication is obviously very important. You know, we talk to the patient to allow them to understand that, you know, you don't need to be too anxious even though you are. And we also utilize medications to help alleviate your anxiety, benzodiazepines and opioids to pharmacologically alter your anxieties. So that's usually what we do.
Wow, what a fascinating career you must have. You meet so many different people, and everyone requires some kind of different anesthesia.
Yes, you have to tailor each anesthetic to each individual. There's no cookbook recipe, unfortunately. So that's what makes our job challenging, and they refer to that as the art of anesthesia.
Wow. Now, the last week in January is just for you. It's a National Nurse Anesthetist Week.
Yes.
And that recognizes all that you do.
Yes.
Anything special you have planned for the week?
Probably
Go to work every
To work
day?
every day, yes, and provide excellent care.
And you, again, Jacob, you are a nurse anesthetist at Altman Hospital.
Yes.
What's it like there in those ORs? So there could be 4 at a time, and is it hectic and chaotic, or is it pretty organized?
It's very well organized. We practice a team anesthesia model where we work with the anesthesiologist and provide excellent patient care for every single patient. And,
of course.
We provide on average 60 to 70 cases a day, and I think it goes very well and very smoothly for the most part.
Well, after 12 years, you're very experienced.
I hope so.
Anything else that patients should know before they have anesthesia? They can always consult you or the anesthesiologist or their doctors and find out what's best for them, right?
Yes. Yeah, the most important thing is to make sure that if you have any coexisting disease, such as any heart problems, lung problems, liver, kidney problems, that you've obviously seen your specialist in regards to that disease process to make sure that you're optimized to have surgery. So if you have heart disease and you've had a heart attack in the past, obviously before you have any type of knee surgery, you need to see your cardiologist to make sure that you are at the best state you can be to be able to tolerate the anesthetic and the surgery, and more importantly, the postoperative care. Rehabilitation tends to be very trying and taxing. So,
And
also,
any medications you're on?
yeah, make sure that you take the medications that you've been instructed to take, and more importantly, not to take the medications that you're not supposed to take, i.e. Sometimes we ask you to stop your blood thinners, aspirin, a lot of NSAIDs such as ibuprofen or Tylenol, and also not to eat or drink anything after midnight.
So that you don't throw up on you.
Yes, and more importantly, not to aspirate, because the nausea is one thing, but it's more that we don't want you to get anything in your lungs.
All right.
To aspirate.
Well, celebrate the National Nurse Anesthetist Week, the last
Yes.
week in January. Our guest is Jacob Click. He is a nurse anesthetist at Altman Hospital. And you have been watching DMG-TV2's Medical Minutes. This has been our first show, so thanks very much for joining us. We will have future episodes coming up as well. And for TV2 and the Medical Minutes, I'm Jennifer Clark.